Good afternoon, everyone, and good morning and good evening to our speakers from Australia and the UK. And it's my pleasure to warmly welcome you all to today's webinar on paracetamol toxicity in children. Paracetamol remains one of the most commonly used medications worldwide, and we continue to see toxicity to be a significant cause of morbidity, including complications like acute liver failure in children. Our next speaker is Professor Angela Chiew, who is a consultant from the Prince of Wales Hospital in Randwick, Australia, who will speak on acute management of paracetamol toxicity in children. And Professor Chiew is an internationally recognized clinical toxicologist and a leading figure in toxicology research and education. And she has played major roles in global toxicology collaborations and has served as a scientific secretary and a key contributor to several international organizations and conferences, including the popular Asia Pacific Association for Medical Toxicology and TAPNA. And she has first authored the updated guidelines for the management of paracetamol poisoning in Australia and New Zealand. That was published a few years ago in the Medical Journal of Australia. And Professor Chiew, we are truly grateful to you for joining us today, despite your very, very busy schedule. Over to you.
Thank you. Thank you for the kind invitation and introduction. So I'm just going to share my slides. You can see the slides?
Yes, we do. Yes.
Great. Today I'm going to talk about the acute management of paracetamol toxicity in children. So this is a brief outline, but what I just want to, in Australia, and I'm sure it's similar in many countries around the world, for children, you really see kind of two peaks of paracetamol poisoning or kind of paracetamol toxicity that you might need to manage. So there's the accidental liquid paracetamol ingestion in very young children, toddlers, and then the intentional acute overdoses in adolescents. These graphs show how many paracetamol poisonings we manage in Australia. The data is a little bit old, but as you can see, it's many thousands of patients per year, so 8,000 to 10,000 patients per year across Australia. And the bottom graph shows you the demographics of these patients. And as you can see, really the bulk of the paracetamol poisoning we see in Australia is young adults and adolescents who take intentional self-poisonings. And actually, accidental liquid paracetamol ingestion is only a very small percentage of that, but I will present our guidelines at the end. So when we talk about paracetamol poisoning, it's really important to understand why patients do develop liver injury with paracetamol toxicity, and then why acetylcysteine is so important, or why antidote is so important, and why it is important that it's initiated within 8 hours in the majority of patients. So paracetamol, or acetaminophen as it's called in the United States, is predominantly metabolized by the liver into two non-toxic metabolites. A small percentage, and it depends on genetic variability, if you start to develop liver injury, but in therapeutic doses, about 5% is metabolized by the CYP450, in particular CYP2E1, into the toxic metabolite NAPQI. So most of us have good glutathione stores, and we can break down NAPQI into its two other non-toxic metabolites, and that's why we can take therapeutic paracetamol, and even we can take reasonably large doses without getting liver injury. However, when the body becomes glutathione deplete, so in bigger overdoses, when you take more than a toxic dose, you completely deplete the liver stores of glutathione, and you can't break down NAPQI anymore. And it's NAPQI that binds to cellular proteins and causes, in particular, hepatic cellular damage. And what acetylcysteine does, it actually is a cysteine donor and replenishes glutathione. It also contains sulfur and also increases sulfation of paracetamol as well. And then I'm sure the next speaker will talk about when you get liver injury, it's also an antioxidant and can help with repair. So really, this whole the whole system of why people get paracetamol toxicity is because of glutathione depletion. So what's really interesting when you actually look at the management of paracetamol toxicity around the globe, it is completely different nearly. It's very different across the globe and across the different countries, from what we even define as a toxic dose, what's an acute ingestion, to what nomogram we use, or even what acetylcysteine regimen we use. Or I know that even in Sri Lanka they do use methionine as well, so what antidotes used. This is just to show you, in Australia, we define an acute overdose as a toxic dose of paracetamol ingested over a time less than 8 hours. The US recently released guidelines and they say 24 hours, and the UK's more, they're stricter. Theirs is only 1 to 2 hours. So what is a toxic dose of paracetamol? In Australia, we define it as a dose greater than 200 milligrams per kilo or 10 grams, whichever is less, taken in that 8-hour period. In the UK, they define it as 150 milligrams per kilo. Just to be different, in the Netherlands, they have a different dose for high-risk patients. And in Denmark, it's even lower. They define a toxic dose as 125 milligrams per kilo or 6 grams, whichever is less. So I'm going to move just onto a case and want you to think about how you would manage this patient. And I'm going to go through the majority of patients take in Australia actually take about 16 to 17 grams of paracetamol. We know from our data they tend to present early. So this is our most kind of common presentation. But then I'm going to present more what we do in like massive ingestions or more high-risk ingestions. So if you have this 14-year-old female who weighs 60 kilos and she takes 20 grams of paracetamol and she arrives an hour and a half post-ingestion. I want you to think about how would you manage this patient, and I'll tell you what the Australian guidelines show. So when these patients present, they all need a risk assessment. You need to confirm on history and examination that that is the time of ingestion and that is the ingested dose. All patients will get a 4-hour paracetamol concentration and LFTs, or in particular an ALT/AST. And this really helps determine, you're really asking yourself two things when you manage these patients. Do they need activated charcoal? And do they need antidote? Do they need antidote acetylcysteine right away, or can you wait for the results of your paracetamol concentration? So what is important on history? It's important, we're not talking about RSTI or staggered, but it is important to determine if it is a staggered overdose over a longer period of time of more than 8 hours. In Australia, we do have a modified release product, which is managed completely differently. So it's important to determine if it's that. What's the dose ingestion? And what's really, really important is actually time since ingestion, because that allows you to plot the patient's paracetamol concentration on the nomogram and also determines, do I need to start acetylcysteine now or can I wait for my level? So what about charcoal? Activated charcoal, and I'm going to show you the evidence of why we offer activated charcoal. So offer activated charcoal to patients who are awake, alert, and cooperative. And so we offer it to within 2 hours post-ingestion in patients who ingest a toxic dose to 30 grams. And if they ingest greater than 30 grams, then we actually offer activated charcoal to 4 hours post-ingestion. And I'll explain that to you why on the next slide. Okay, so when you offer charcoal, really you're weighing the risks and the benefits of charcoal versus the benefits in a paracetamol overdose. And so the risks in an awake and alert patient are very, very minimal. If your patient's awake and alert, the risks of aspiration are less than 1%. But what's the benefit? Well, it decreases the need for acetylcysteine, and I'll show you the data for that. Hence, if you don't need acetylcysteine, it will decrease your length of stay. And in bigger overdoses, it's shown a trend, but it wasn't statistically significant, that it may decrease your risk of liver injury. And it does that because it basically lowers your level. And those patients, as I'll explain, in massive overdose who have very high initial levels are at increased risk of liver injury. So what's the evidence for charcoal? So the two kind of main observational studies are done in Australia by the HATS, or the Hunter Area Tox Service. The one done around the 90s was by Professor Buckley, and he looked at observational data and looked at patients who received charcoal and didn't receive charcoal. And what he found is those that received charcoal, only 15% required acetylcysteine, while those who didn't get charcoal, about 41% required acetylcysteine. So by administering charcoal, you lowered the paracetamol level, lowered them to below the nomogram in some cases, and then they didn't require treatment, hence decreasing their length of stay. Steve Duffel and Jeffers Vista, then in the same data set, but further on in time, so from 1997 to 2011, again looking at HATS patients, looked at what was your probability of needing acetylcysteine if you're given charcoal. So that black dark line are those patients who don't receive charcoal, and the dotted line are those who do. And as you can see again, what you see is people who get charcoal are less likely to require acetylcysteine. What's nice to see with this data as well, obviously the more you take, the more likely you are to receive NAC, which makes sense. If I take a bigger dose, I'm more likely to be above the nomogram line. And there gets a point at about 50 grams where nearly everyone will be above the nomogram, regardless if you have charcoal or not, just because it's such a big dose of paracetamol. So this is the nomogram that we use in Australia. We always tell the doctors to be mindful to check the units. So there's mass units and mole units. Even unfortunately in Australia, there's different units used by different hospitals, and that can cause confusion. But what's important also to note is that the nomogram is really only validated for immediate release preparations. Acute ingestions, what that actually means has never really been properly defined in the literature, but in Australia we say it's less than 8 hours. And what's really important and has to be a known time of ingestion, because you can't plot on the nomogram if you don't know the time of ingestion. This is just to remind people that different countries use different nomogram lines. So the UK now uses a lower line that starts at 100 milligrams per litre at 4 hours. And some countries don't use a nomogram line at all. In Denmark, they treat all patients who take more than a toxic dose. For them, is 6 grams with acetylcysteine. But in Australia, we use the nomogram. So who do we need to start acetylcysteine on? So if you can get a paracetamol level back so that you can start acetylcysteine within 8 hours, then you can wait for the level and plot it on the nomogram line. However, if you can't get your level back and be able to start acetylcysteine within 8 hours, then you should treat all those people until you can get a level and an LFT back to risk stratify those patients to stop NAC at all. So in Australia, we can get paracetamol levels back in nearly all hospitals, except for rural hospitals, in a timely manner. So if a patient like this patient I've presents early, then we can wait for the level. If she had presented late, say at 8 or 9 or 10 hours, then we would just commence acetylcysteine on arrival. We would do her paracetamol concentration and ALT, and we'd only stop acetylcysteine if both the concentration was below the nomogram and ALT was less than 50. In some rural sites, we can't get paracetamol levels in a timely manner, so often we'll just run the full course and do their LFTs, do their liver function test after the full 20-hour course. Okay, so what acetylcysteine are we going to start these patients on? So traditionally, and what was proposed for the IV acetylcysteine by Prescott was a 3-bag regimen. I've just shown it to you there. In America, they tend to use the oral regimen, which is shown here. In Australia, we always use IV. But what's happened really, and since the 2020 guidelines, it's become the recommended or the guideline recommended acetylcysteine in Australia is the 2-bag regimen. So what we've done is pretty much, if you look back here, is just join the first 2 bags. That 150 milligram per kilo over 1 hour and the 50 milligram per kilo bag have been joined together into a 4-hour bag. And then that last bag is the same, 100 milligrams per kilo over 16 hours. In the UK, they've also gone for a 2-bag regimen, but it's quite different. It's shorter. It's only 12 hours. The loading dose is 100 milligrams per kilo over 2 hours, and then 200 milligrams per kilo over 10 hours. If they need to continue, they continue that second bag for 1 more dose. And then you will see sometimes in the American literature, a one bag protocol, but it's actually a two-step infusion like I've shown here. This protocol needs a special pump that you program. So we haven't gone to this protocol in Australia. We do the two-bag protocol. And what's the reason we've seen all these new protocols? It's because actually adverse effects were common with the three-bag IV NAC, and that was because of the loading dose. So quite a few people got a anaphylactoid reaction, which would often lead to NAC being stopped or slowed down. The infusion schedule was quite complex with the three bags. And we always, which we'll get to next, this doesn't deal with it, but does one size fit all? And do we need to adjust actually the dosage in some patients? So what's the evidence is, we've all changed to two-bag NAC to support it. So this is a systematic review by John Cole from the US, and he looked at all the published data for two-bag regimens versus three-bag regimens. And as you can see from the forest plot, that the two-bag regimen has much lower anaphylactoid reactions. And I have to say, since we've had the two-bag regimen in Australia, we've had it in our unit for maybe 10 years, I've only treated one anaphylactoid reaction in that 10 years. And I remember before that, we used to treat quite a lot, like quite a few per year. So it's been quite good moving to the two-bag regimen. So back to this patient, we follow the Australian guidelines. We would offer her 50 grams of activated charcoal. Then at 4 hours, check her paracetamol concentration and ALT. And if her concentration was above the 150 milligram per litre at 4 hours nomogram, then start her on acetylcysteine. We run all the patients on the full two-bag infusion, and then 2 hours before completion, we'll repeat their ALT. If they have a very high paracetamol level, more than double the nomogram, then we'll also repeat their paracetamol level, but otherwise we don't do that. And then they don't need any further acetylcysteine if the ALT remains less than 50. If the ALT rises, which is actually, I'll show you, is quite rare if you get presentation within 8 hours, and get treatment within 8 hours. But if they do get an LFT abnormality, then we just continue that last bag at 100 milligrams per kilo of acetylcysteine over 16 hours. So just briefly, we do all this research looking at, how can we prevent people getting liver injury? Do people who take massive overdoses, can we prevent them giving liver injury? But actually one of your largest risk factors for getting liver injury from paracetamol toxicity is your time to treatment, which often we can't change if they present late. So we know that we kind of use this 8-hour rule, but really can happen at 7, and you do start to see a little bit of a signal at 7. But from 8 to 10 hours is when we start to run out of our body's glutathione store, and then we start to get liver injury. And so your biggest risk factor actually for getting acute liver injury from paracetamol toxicity is time to treatment. Other risk factors are definitely your high initial paracetamol level, and I'll show you some data from the UK. But then there's also patient factors which you can't predict. So if the patient's more glutathione deplete, so are they malnourished, anorexic, people who abuse ethanol, or there could also be genetic factors. So we do know in certain populations, such as Southeast Asia, they have a lot less liver injury from paracetamol toxicity than certain other populations. What typically happens, I'm sure the next speaker will talk about, is the majority of patients actually recover. 95% of patients recover and their liver function tests return to normal with good care. And so the question, and what I've done some research on is, do we need more acetylcysteine in large overdoses? It's quite easy to get large doses of paracetamol in Australia. So we have this 100 box size, which we can buy for only $2 Australian. Recently, new legislation's come in. They've gone down to 50 tablets per packet, but it's still a lot of tablets that you can buy all in one go. So data from the UK from both Carney and Marks in 2 separate studies actually showed that patients with high initial paracetamol levels had a higher risk of hepatotoxicity despite time to treatment. So what does that mean? I mean that we used to always say, oh yeah, it's good if you get treated within 8 hours, but we do know that those with high levels, so kind of double, triple the nomogram line, would still get liver injury despite early treatment. And if we think about how paracetamol causes liver injury, theoretically it makes sense because the traditional NAC regimen wasn't developed, didn't have any dose-based studies. It was just basically an educational guess. They developed it working out what they thought the body's glutathione depletion was. It presumed we had a conversion of NACQI of about 6 to 10%, but actually it's a lot higher when you start to get liver injury. And it was proposed by Rumack and Bateman and various people that maybe the standard dosing of acetylcysteine may be inadequate in those with high paracetamol concentrations. And then toxicologists such as Hendrickson have written papers, although they're completely theoretical, that should we be increasing the acetylcysteine even more in those with even higher doses. So, for example, it's been proposed if my initial level is triple the nomogram line, then I get triple the acetylcysteine in that last bag, and then quadruple. But what's the evidence for this? The way I like to conceptualize it better than how I've just said it is really, if you think about it, when we give someone acetylcysteine, we give it based on the patient's weight and not on the paracetamol concentration. Maybe if we could go back, we would have changed that. So if you think about if you have two teenage girls who present and one's 50 kilos and she ingests 50 grams of paracetamol and her friend's 100 kilos and ingests a much smaller ingestion, actually the girl who's bigger ends up with a lot more acetylcysteine, even though the other girl has a much, much higher level of 450 milligrams per litre. And so maybe this also plays into that as well. So in 2017, I did an observational study. What's happened in Australia, we started seeing people getting liver injury like they did in the UK, with high initial levels still getting liver injury despite treatment within 8 hours. So some toxicologists started increasing the acetylcysteine, especially after the Rumack-Bateman paper, in those with very high levels. And so we just looked across time, was there a difference in their rates of hepatotoxicity if they got given increased acetylcysteine dose? And what we did find is that patients who got increased acetylcysteine did have less hepatotoxicity than those who got standard acetylcysteine. Why I like to show this graph is what you can see is we really, if you actually look at it, we actually just changed those presenting within 8 hours. Because if you present late, you'll deplete your glutathione, and it doesn't matter how much acetylcysteine you're giving, you might not be able to prevent the liver injury. So we changed our guidelines in 2015. It was changed as a suggested, and it became a recommendation in 2020 that all those people who had an initial level more than double the nomogram line, that they should receive increased acetylcysteine. So we just increase, the loading dose remains exactly the same. It's just the second infusion goes from 100 to 200 milligrams per kilo over 16 hours. Sometimes we do use higher doses. We never go more than 4 times, and it depends on the individual toxicologist. But generally, if it is more than triple, we go triple, and some people will go to quad, but it's not consistent across Australia. So now, since 2017, there have been various other papers, and what's the evidence for it? Should we keep doing this? And actually, there's now 4 papers in total. There's probably soon to be more, and Australia's now looking at it again as well. But what I just want to point out when you look at all this evidence is that unfortunately we've all used different inclusion criteria, and we're all looking at very different groups, which makes the evidence very hard to interpret. So in my initial ATOM2 paper, we just looked at people who ingested greater than 40 grams, and then we looked at a subset with a very high initial level, greater than double the nomogram line. Shah just looked at late presenters, so those presenting after 8 hours, and looked at multiplication products as his risk factor. Lewis just looked at those with levels greater than double the nomogram line, and so did Moss. And so this slide is quite busy, but it's just to point out that the groups are very different. And what's really important is looking at time to treatment, because as I said to you, time to NAC is a really big risk factor for liver injury. You can see in the ATOM2 study, time to treatment is about 6.3 hours. In all the remaining studies, it's much later, it's about 10 hours. And what we see is 2 studies found a benefit for increased acetylcysteine and 2 showed no benefit. So what does this mean? It means that we probably need more studies. And I saw James Deary is one of the speakers. He's currently doing a trial on this, which will be great. But really, it makes it quite hard to compare these studies. The difference in inclusion criteria make the studies, you can't compare them to each other. It makes me raise the question, is it the absolute paracetamol concentration which is important rather than the ratio? I don't think we know that yet. Does the dose you ingest actually matter? So having a higher dose, Adam 2 was only patients who took more than 40 grams. Does increased NAC actually improve outcomes? I don't think we know completely yet, and I think we definitely need further studies. So sorry, briefly, I'm just going to go over, if I've got time, liquid paracetamol ingestion. And this time I just want you to think about a 3-year-old male who ingested, like he's seen with the bottle, like this little child in the picture, and he could have ingested up to 170 milligrams per kilo. And what management would you do? Do you give charcoal? Do you do a paracetamol concentration? Do they enact? Or can you just send them home? So this was the Australian guidelines in 2015. We wouldn't even assess this child. So basically, if the Australian guidelines is you only get sent to, if you're otherwise well, have had no other doses of paracetamol, and the ingested dose is definitely less than 200 milligrams per kilo, that child remains at home and only to present to hospital if unwell. If they have potentially ingested a dose greater than 200 milligrams per kilo, then they'll be sent to hospital for a paracetamol level. And that paracetamol level is done at 2 hours, just to try and get the child out of hospital earlier and decrease the burden on the ED. And what's the way you assess, we said to assess that level is if that level is less than 150 milligrams per litre at 2 hours, then the child could go home. And they didn't need any further investigations. However, if the level was greater than that, then we'd do another level at 4 hours, and that level would determine need for treatment, like the adult protocol. And this protocol was purely developed to make sure kids could get out of hospital earlier, and that not all kids needed paracetamol levels if the dose was low. So why did we have this guideline? It's because children 1 to 5 years of age are actually less susceptible to toxicity than older adults in acute ingestion. So repeated supratherapeutic ingestion is different, and there have been children who have got quite sick from repeated supratherapeutic ingestion. But I'm not talking about that. I'm just talking about an accidental liquid ingestion in a otherwise well child. And when you look at acute ingestions in children, if they have a paracetamol concentration greater than the nomogram line, actually their risk of liver injury is quite low, less than 5%. And Anderson, who's a New Zealand researcher, he actually did a pharmacokinetic pharmacodynamic study. He simulated 1,000 patients and compared it to 121. And what he found is that the maximum concentration in this simulated PK/PD study occurred before 2 hours. And actually, if children had to ingest more than 250 milligrams per kilo to get a toxic level. This was a very old paper, so a toxic level back then was 200 milligrams per litre at 4 hours. So this led, and he proposed that you could do a 2-hour level and could actually probably clear people as long as it was less than 225. So that's why Australia changed their guideline. However, in 2024, Dr. Ong and Darren Roberts from the New South Wales Poisons Information Centre, we decided to actually, so we did this change of guideline, evaluated how did this go in kids. So over, it's about a 5-year period, they looked at 271 children who, so you have to remember that most of the children don't get referred to hospital if they ingest less than 200 milligrams per kilo. So these are children who either were suspected of ingesting more than 200 milligrams per kilo or turned up to hospital, so they hadn't called the New South Wales Poisons Information Centre. They were all acute ingestions. The median age was 24 months, and they tended to present early. About half had a paracetamol concentration, so they would have been following the Australian guidelines, and 62 occurred at 2 hours. So what's really interesting, we looked at, so out of all these kids who are presenting, how many actually needed a repeat level and had a high initial level? So that's what this graph shows you. So 23 got repeat testing. As you can see, quite a lot got repeat testing who didn't need repeat testing. They were well below the 150, and some of them were quite low. And the majority of these repeat levels actually decreased. But what we found, which they didn't find so much in the simulated one, was that actually 4 did have an increasing level. 19 children were given acetylcysteine. The majority actually didn't need it, so didn't follow the guidelines. Only 6 had a toxic level above the nomogram. 3 were late presenters or so that's why they got given acetylcysteine. So what they found in this observational study that actually, look, 2-hour level is pretty good and allow most of the children to go home and allowed to facilitate medical clearance early. However, what we did see is 3 kids actually had an increase in level, and that increased at most was at about 50 by 50 milligrams per litre. So this led us, and it will be in the next guideline, but it is published on what we have ETG, which is an internal guideline across Australia, but it will be published in the MJA next. We've actually lowered the threshold just in case. So we still only assess children who ingest more than 200 milligrams per kilo, but now we only let them go home if that level at 2 hours is 100 milligrams per litre. So we've just put a bit more of a safety into it, just in case potentially the level could go up by 50 milligrams per litre. Just before I finish, I just want to bring to note there actually was one case that developed hepatotoxicity, and this is why it's important to actually do a risk assessment. This was a child who was not well, had a viral illness for many days, had only 1 previous dose of paracetamol, and had mildly abnormal ALT of 54 on presentation. So shouldn't have completely fell into the guidelines, but interestingly did have an initial level below the nomogram and still got liver injury. So probably also due to viral hepatitis. And very lastly, if I have time, just a case of neonatal paracetamol toxicity. This is a case that I managed. Neonatal paracetamol overdose is very rare because usually it's an error by the parents, and that's what happened here. It was a 2-year-old full-term male who was due to have some, I think it was actually due to have a circumcision, and he was accidentally administered 600 milligrams of paracetamol, liquid paracetamol, just because of dosing error. So that was 200 milligrams per kilo of paracetamol. So he was sent into hospital to have concentrations done. And so he had a 2-hour level and a 4-hour level because he was pretty close to that 150. He was over the 150 mark at 2 hours. And he was actually sent home because they said, oh, look, he's below the nomogram, sent him home. The case was actually discussed with the toxicologist after the child got sent home, and they said, oh, it's very close to the nomogram. I actually think you should probably have treated that child. So the child was recalled. But the child came back in at 17 hours. They were well. They had a repeat level at that stage, and you can see it's above the nomogram, and repeat LFTs that were normal. And the child had a full course of acetylcysteine and made an uneventful recovery. What's interesting is we actually did metabolites on this child to see there's actually not much known on neonatal toxicokinetics of paracetamol. There is some data in therapeutic doses. And what we found is that the apparent half-life in this child was about 9 hours. After acetylcysteine, it becomes 3 hours. And as I said, acetylcysteine actually donates sulfur, so it can improve metabolism. And the percentage of glucuronidation was mainly sulfation. We know that in neonates, and the amount of CYP metabolites was 5% in this child. So we do know neonates have a lower capacity to metabolize therapeutic doses of paracetamol, and not until a year do they reach adult capacity. Existing guidelines are based on adults. There's not a lot of data in neonates. There's another case report from Jeffers Vista, which has very, very similar kinetics, so very long half-life, didn't get liver injury. And so in these neonatal cases, this case didn't get liver injury despite early NAC, and it's likely that their long half-life is just slower metabolism and not liver injury. For now, we will continue to treat them as we treat adults because there's just not enough data. But they may be protected because they have less going down the CYP pathway. So that is my final slide. And my take-home message is that actually most overdoses can be managed by standard protocols. In Australia, most of our patients present early and do well. Don't forget about decontamination. Charcoal is actually really good for paracetamol and decreases your need for NAC. Be aware of high-risk situations, and most accidental liquid paracetamol ingestions don't actually require treatment. Thank you. We'll stop sharing.
Okay, thank you so
No
much,
problem.
Professor Angela Chiew. for taking your valuable time to enlighten everybody who has joined here. So I hope you have a great day, and thank you very much once again.
Thank you.
Thank you.